This is another early movement disorder patient. Frequently, when a patient has one thing wrong with them, they have several things wrong with them. And as you can see, when this patient opened his mouth, his tongue was at a slant, as if the nerve to one side of the tongue was not working. Recall your anatomy if you can and identify what nerve this is. It is the left hypoglossal nerve, number 12. He has right frontal headaches, and this is his occlusion. You can see from the front the amount of overbite and overjet he has. This is the right side on the left side of the screen, and the left side of his occlusion on the right side of the screen. You can see his overjet is increasing, and he is creating an anterior open bite. Basically, this is a relapsing orthodontic case. When you see protrusive maxillary incisors, an anterior open bite, an increased buccal overjet, and antigonial notching, which you would look for on your Panorex X-ray, suspect an internal derangement with degenerative joint disease on one or both sides. This is his range of motion measurements, and you can see he opens straight up and down until 42 millimeters, and then he deviates away from the midline and then back to it, and ends up opening at 55 millimeters. You'll only pick up these deviations if you have him open his mouth very, very slowly. He can move his mandible laterally to the left and to the right, only 5 millimeters in each direction. Normal is 12 millimeters. 12 millimeters is merely a half an inch. If a patient can't move his mandible a half an inch to the left or a half an inch to the right, you should suspect that something is wrong. When we palpate around his head in all the structures, no muscles were in spasm. Why would there be no muscles in spasm? Usually there are. The reason is he's a flaccid paralytic, and the muscles don't work correctly. None of them are in spasm on the examination. This is his history that he gives of his symptoms. Migraine headaches, much neurological testing. His medical file, he states, is several inches thick. He has trouble walking, and which most of these movement disorder patients do have. He has mental confusion, can't remember anything. He's been classified as learning disabled since very early childhood. He's had orthodontics from 14 to 16 years of age, which is relapsing. He's had 4 bicuspid extractions. He's had cervical headgear, and his maxilla is over-retracted due to wearing the cervical headgear. This is his cephalometric X-ray showing the antigonial notching in front of the gonial angle. He also has a constricted airway, which you can see posterior to his palate. His frontal X-ray shows occlusion of the nasal fossa with overgrown turbinates. So therefore, this patient has 4 strikes against him: an obstructed nasal airway, an obstructed pharyngeal airway, which you saw in the previous slide, C-spine degeneration from the previous slide, and a non-functional hypoglossal nerve. His left condyle is supposed to be nice and round, about the size of a dime, and you can see it's bent forward and comes to a point. His right condyle is flattened off and comes to an osteophytic point on the anterior superior surface. Here is a close-up of the right side, eccentric occlusion. This is not a normal condyle. You can see its outline here, coming to a point and then back. This is the left side, wide open, which you would suspect at 55 millimeters interincisal opening, where the condyle has come past the eminence right here and is separated from it. This is his occlusion from the right side, showing that the orthodontic result is relapsing. This is the occlusion on the left side. It's a little better, but still relapsing. This is the splint that the patient was wearing when he presented to my office. It's a little teeny-weeny splint that people make to put on the back teeth to eliminate interferences, because they think interferences cause muscle engrams, which causes the pain. As you can see, it wouldn't do a bit of good in this patient's case. It's very harmful, in fact, because it's the wrong design. You put that little splint in his mouth, and his mandible goes posteriorly, increasing his anterior overjet, or protrusion of his teeth. When you take it out of his mouth, the protrusion of his teeth lessens, so the splint is causing him harm and making him worse by posteriorizing his mandible. On the left side, you can see the harmful version of the splint posteriorizing his mandible, worsening his osteoarthritic degenerative problem. On the photo on the right, without any splint, the patient's body repositions the mandible downward and forward, decompressing the tissues of both joints. This is the repositioning splint we used. It is a highly indexed splint where the patient can bite in only one position. This is what it looks like out of the mouth. Here he is opening 54 millimeters, and you can see his tongue is already getting better on his left side. This is the patient at the end of treatment, and you can see his mandible has been repositioned in an end-to-end position. This is centric relation with the disc in place. And now the second stage, and there is always a second stage to address the occlusion of the teeth, is fitting the teeth together on the sides. We do this again with a maxillary expansion appliance to accommodate an advanced mandible, put teeth on the upper arch, and level and align the teeth. On the lower arch, we put composite buildups and brackets on the rest of the teeth and level and align them. We put a molar tube on the second molars as high up as we can, even if it's on the composite buildup. This is the patient at the end of stage 2 orthodontic treatment. Can you see a difference in his tongue now? When you correct one thing, usually the other things that he has wrong with him self-correct. This was him before and after. You can see the difference in his tongue right away. This is his condyle at the end of treatment. If you remember how it was originally, it is more substantial and bulked up now. This was it originally, and see how thin and narrow and tapered it was at the end. This is a comparison before and after. The condyle is much more massive now than before. This is the right condyle after treatment, showing that it too has changed shape. This is the right condyle before treatment, showing how flattened it was at the top and coming to a point on the front. This is the before and the after of the left and the right sides. You can also see that the glenoid fossa has more definition, the eminence has more definition, the condyle is bigger. Everything is better afterwards than before. When making tracings of the left and right sides before and after treatment, and superimposing them on the intervascular bundles on each side, we can look up and see the increase in height in the condyles, and it has increased approximately 3 to 4 millimeters on each side, at least 3 millimeters on the left, and possibly that much or more on the right. Okay, this is his left side wide open before on the left side, and afterwards on the left side. And the right side is before on the left and after on the right. This is the patient as he came in 6 years post-treatment. You can see the improvement in his tongue is holding, the interincisal opening is holding, everything has been stabilized at this improved position, and he is now off welfare and working and is contributing to society. These were the x-rays that we took at that time, 6 years post-treatment, and you can see the improvement in the condyles are continuing to hold. The take-home message from this patient is that only anterior repositioning appliances are capable of making these changes, and they are capable because they mimic normal mandibular growth. This is the anterior repositioning appliance. This is normal mandibular growth where the weight of the mandible distracts it from the base of the skull, and it tends to grow back in the direction the arrows are pointing.